thank y'all for being here, first of all. I know there's plenty of things you can do. You know, there's a lot of events that happen here every day. I'm really honestly impressed. But just by a show of hands, how many of you have had or currently have foot problems?
Does that include nails?
Yep.
That includes
Anything that you feel like is wrong with your foot. So that's more than half of the room. So hopefully today you can learn a little bit about maybe some problems you might resonate with in this presentation, or if you have family members or friends and you see them limping, you can say, oh, you know, what's going on with your foot? I know someone I can send you to. So a little bit about myself. I was born in Nashville. I have no accent, but I was born in Nashville, grew up in Smyrna, so here in Rutherford County. I live in Murfreesboro now. I did my undergrad at University of Memphis, so I stayed local. I was actually one of the first original recipients of the Tennessee Hope Scholarship. I am triple board certified, and what that means is most podiatrists you'll see may have a single board certification. Nothing wrong with that. I am just an overachiever, I think. But I am triple board certified in medicine related to foot and ankle, and also foot and ankle surgery. I started my own practice in 2021 in Murfreesboro and McMinnville, and we'll just get started. So today we'll go over brief anatomy. So it's not a science class or anything, but I think it's important to kind of be on the same page when we talk about terminology. We'll go over the common foot and ankle conditions I see. It's not all-inclusive, meaning we could spend days going over anything and everything related to the foot and ankle, but we'll go over the common ones that you may have heard of or may have dealt with. Diabetes and foot health, something I'm really passionate about, something very important. We'll talk about that. Choosing the right shoes. I get asked this all the time. Even when someone asks me who's a stranger in passing, I could be at the grocery store and they'll say, oh, what shoes do you recommend? And last is just my little spiel on why movement is medicine. All right, so what is a podiatrist? Well, they're called a podiatrist. You may hear it called, them being called a podiatric surgeon. That's a surgical podiatrist. Not all podiatrists do surgery, of course, but anyone who's trained in the last 20 years or surgical, you may hear them called as a foot and ankle specialist, foot and ankle surgeon, or a podiatric foot and ankle surgeon. So you may have heard of an orthopedic foot and ankle surgeon, so that's going through the orthopedic route. Podiatric foot and ankle surgeon is going through the podiatry route. Again, we do 4 years of undergraduate schooling, 4 years of podiatric medical school, and a minimum 3-year surgical residency. So we are all about feet and ankles from day one. All right, so the anatomy. There's 28 bones in one foot, so that's a lot of bones, a lot of weight and stress that gets related to our bones. There's 33 joints, and again, this is per foot. So our toes here are actually, except for the big toe, our toes, our second, third, fourth, and fifth toes all have 3 bones. Our big toe only has 2 because it's a larger bone. And then the bones behind the toes, we call it the metatarsal, the long bones. Our ankle, some people may include the heel bone, the calcaneus, as part of the ankle. The talus is what connects the foot to our leg, so that's really the main ankle bone. And then you have your shin bone, which is your tibia, and your outside ankle or leg bone is your fibula. And these are all the muscles in our legs and our feet. So there's over 30 muscles in one foot and ankle, and then over 100 ligaments within one foot and ankle. So very dynamic structure, very important part of our body. We take it for granted when we don't have pain because it's keeping us moving forward. Whatever your hobbies are, whatever your day-to-day life is, our feet need us to move forward, and it's our foundation. So how many of you know that we have 3 arches in the foot? All right, I saw 2 hands. So we actually have 3 arches in the foot, and I take time in the office to explain this because it plays a role in how your foot deformities or foot pain happen. The exception would be if you have, an outright injury like a sprain or a fall or something drops on you. But most foot problems happen because of abnormal biomechanics. And what that means is one of the three or all of the three arches tend to collapse or be too high over time. So the instep is the medial longitudinal arch. So it's, if you follow your big toe to your heel, that's your medial arch or instep. As far as the outstep or the lateral arch, if you follow your pinky toe to your heel, that's the outside arch. And then the arch behind the ball of your foot, we call that the transverse arch. And if you look at it, it's almost like a triangle. So anyone who's into architecture, when you look at bridges and buildings, you have a triangular truss, and so it's a very stable construct. So God knew what he was doing when he developed our feet. Now, with walking, you can see the heel needs to be lined up. We're looking at the foot and ankle from behind. The heel needs to be lined up with your ankle and with your leg. And so over time, if you have more of a flat foot structure, that means you pronate too much. And what that means is, here's the inside of your ankle, here's the outside of the foot, inside of the foot. So this is a right foot looking at it from behind. So the heel tends to go out. You see more of your third, fourth, and fifth toes from behind. Your ankle looks like it's caving in. So that's called overpronation. We see that often with flatter foot people or arches that start to drop. The opposite is supination. So the heel is going inward, your ankle is going outward. So you're more prone to having ankle sprains when you have a higher arch foot. Again, this is looking at it from behind. So this is too much pronation where the heel kicks out. You can see, the last 2 or 3 toes. You should not be able to see that in a normal foot. So this is normal walking. So the heel is lined up with your ankle and your leg. As your heel hits the ground, by the time you're pushing forward, all of your weight is going towards your big toe, which helps push you forward. So that's normal walking. So you have all your weight distributed evenly. So people with normal feet won't have this issue. So this is pronation. Heel is too much out. So the weight distribution is abnormal. Here's the opposite. So higher arch people, you can see, you can't see the outside toes, right? You can't see the pinky toe, but you can see the big toe more. So the heel is going in, the ankle is going out. And you can see based on high arch feet, they're more prone to rolling the ankle, spraining the ankle. This is just an animation showing that. So see, the heel stays in too much. So you tend to have a lot more pressure on the outside of your foot. All right, so why is this important? Well, it's important to explain to patients, we know where you're hurting, we know why, but if you really know why, then you understand why we talk about the treatments that we recommend. So whenever your heel is being pulled in or out, our Achilles tendon or our heel cord attaches to the back of the heel. So whether it's going outward or inward with pronation or supination, you're pulling that Achilles tendon with it, and that makes it short. So your calf muscles tend to get tight. So if you ever had plantar fasciitis and seen anyone about it or Googled it, it always talks about stretching the legs, and that's why. So the superficial calf muscle is called your gastrocnemius. Deep to that, underneath that, is your soleus. So one or both of them could be tight. So we'll go on to common foot and ankle problems. All right, so I mentioned plantar fasciitis. Anyone here has had plantar fasciitis? I have. I'm kind of dealing with it now, to be honest. But it's basically where you have inflammation of this ligament. So the plantar fascia starts at the bottom of the heel and goes all the way to the ball of the foot. So it helps to support those 3 arches that we talked about. You can see there's little bands that separate towards the toes there. The more common place that people have pain is kind of on the bottom or on the sides of the heel, and that's where it tends to get tight. And so what happens is by the time you feel pain, at that point it's already tearing, and so you get a lot of inflammation, a lot of pain. Before it gets to that point, it actually becomes irritated, and again over time, because your body can't get rid of that inflammation on its own, it will start to, that's when it sends a signal to your brain, hey, something's wrong, this is painful. So what can cause that? Well, repetitive stress on the foot. People who, I hear this a lot, they want to lose weight or exercise, and so they start walking 2 or 3 miles a day all of a sudden without warming up or without stretching, not having the right shoes, maybe not having the right arch support. You can have it in people who stand too much. So I see a lot of factory workers, if they're on their feet on concrete, they're just constantly standing. Again, we talked about running, of course, can do that, and that leads to not stretching or warming up enough. Anyone play pickleball? So there's been, pickleball has been around for a long time, but it's been more popular in the last 5 years. We get injuries, plantar fasciitis related to that, but it all stems to not stretching enough, not warming up your muscles and your tendons. So how do we treat it? Well, the good news is that 98 to 99% of my patients don't need surgery. And we'll talk about if you need surgery. And so we always start with stretching. We look at your arches. Are you pronating too much? Are you supinating too much? If it's not full of arthritis, then you would be a good candidate for a shoe insert or insole. Arch supports, same thing. Or you can do a custom orthotic, where they take a mold of your feet and make one for you. Again, I'll look at everyone's shoes. Hopefully, when you come into the office, you'll bring your shoes. Sometimes people will just wear sandals because it's easier to take on and off, and they'll say, I promise I'm not wearing these sandals to walk or exercise in. Again, if you go from not walking for exercise to all of a sudden doing an hour, and you're not warming up and stretching and your shoes aren't good, you're going to have issues with your feet, and again, heel pain is more common. Ice is actually a natural way to reduce inflammation. I typically recommend an hour total, but only 20 minutes at a time, and always use a washcloth so you don't get blisters on the skin. Sometimes we need a little help from medicine. If you don't have any contraindications or any reason why you can't take ibuprofen or Aleve, I typically will recommend that for just 3 days, so it's not like you have to take it forever. Sometimes you need some extra padding and support. And the last thing, I don't do this often, mainly because traditionally when you prescribe this night splint, it's a brace that you wear overnight. I wouldn't be able to sleep with that brace on. It's just not comfortable. So what we do instead is, while you're wearing it, it stretches you. So if you want to fold laundry, if you want to watch a TV show or the news, for 30 minutes to an hour, you can put that on while you're awake versus wearing it at night. The second line would be physical therapy. So let's say we tried everything on that last slide. Physical therapy is a great way. They can diagnose if you have tight hips, tight hamstrings and quads, because that does play a role in tight calf muscles. Steroid injections, again, I tend to like to do these if it hasn't been something you've been dealing with for a year. If you've been dealing with plantar fasciitis for a year, then at that point it's scar tissue. It's not inflammation, in there. So a steroid shot, shockwave therapy, PRP, which is platelet-rich plasma. They take your blood, spin it, and we inject white blood cells, the leukocytes, which help with inflammation and scar tissue breakdown. And this last one, the stem cell injections, these last 4 are not covered by insurance, so it is out of pocket, but there's been good successes with these treatments, plus the first slide that we talk about, stretching, the right shoes, and if you need it, the right insoles. And then for those who are that 1 to 2% where you've tried everything and it just will not get better, there is a surgery option. Most people are doing it endoscopically, which is minimally invasive. So here's a quick video showing that. You make a cut on either side of the skin, you stick a camera in. So this is the camera view. Then you take a blade and you typically cut about 50% of that ligament, so it permanently stretches it. And what I'll do in addition to this too is the calf muscles are tight, so I'll lengthen the calf muscles as well. All right, the next will be back of the heel pain. So we talked about bottom of the heel pain. Back of the heel pain will be if you have Achilles tendonitis. Now for some men and women, if they like to wear boots or high heels, you'll get what we call a pump bump or a bump on the back of the heel. And what that is extra bone growth because of the heel constantly rubbing that high heel or a wedge shoe or a boot. But typically this all stems from having tight calf muscles again. And the point of the Achilles tendon is to connect our calf muscles to the heel bone. It helps us walk, it helps us lift our heels off the ground, it helps us climb the stairs and go on our tiptoes. So what can cause tendonitis and tendinosis? So anytime you see itis or tendonitis, that means it's inflammation. If you see nosis or tendinosis, that means it's more than inflammation. There's scar tissue and degeneration of that tissue. So those are a lot more stubborn to treat. Tendonitis is usually something that happens within a week to 6 weeks where it's pretty inflamed. But if it's been going on for years, you may have some inflammation on top, but underneath that, the tendon is, degenerating. But again, sudden increase in activity. Let's say you don't walk for exercise and you decide to go to your grandchildren's soccer game and you're standing more than you do and walking more from the field to your car. Well, and not having the right shoes. So that will flare up either the heel pain on the bottom or on the top. Again, this all leads to not having enough stretch in your calf muscles. And what tends to happen is because it's so tight, your body wants to help you out by stretching it. And how it does that is it tears, not in half, but it's like a split tear. So if you think of a rope and the strands kind of tear off or split off, that's what happens with your tendon and your plantar fascia. So how do we fix it? Well, again, if rest is a good way, if you are walking 2-3 miles a day, we'll probably cut it back to, maybe half a mile, just so you're moving, but giving it time to rest. Again, I'm a big fan of icing. If needed, we can do anti-inflammatories for about 3 days. And then a night splint, again, the goal of that is to help stretch the tendon. And we teach you some stretching exercises as well. Physical therapy is a good way to help with that. And sometimes we need a little heel lift. So for men and women who wear cowboy boots or anything that has a little bit of a heel, when you go to a regular flat shoe, sandal, or barefoot, your heel has been lifted for so long, so it's inherently made that tendon short and tight. Now, as far as surgery, we don't have to do surgery, luckily, a lot on these. The only exception would be if you have a really, really big bone spur on the back of the heel that you can feel, and it's cutting into the tendon. And how we usually tell that is with x-rays and or MRI. All right, ankle fractures. So podiatrists can treat ankle fractures both conservatively and surgically. Most ankle fractures I see do require surgery, but if only one of the bones break and it doesn't separate too much, then you can treat it conservatively. Usually you're in a short leg cast for a limited time and in a tall cam boot. With surgery, again, if it's out of place, if it's in many pieces, if it's really unstable, if you don't fix it, you'll definitely develop arthritis within a year, not to mention deformity and constant pain. Foot fractures are the same. I think it's pretty common, especially if you go from zero activity to a big jump in your activity and you're not wearing the right shoes and stretching. We see stress fractures a lot. Even in people who maybe they don't run as a hobby, but they're motivated to do a 5K walk or run. Because you're increasing the mileage you're putting on your feet, that can lead to stress fracture. And stress fracture is repetitive stress. So you may not always see it initially on x-rays. It takes at least 2 weeks from the time your foot hurts for a stress fracture to show up on x-ray. Another common fracture is, let's say you step off a curb and you misstep and your foot twists. Most people think of, oh, you have an ankle sprain, but you'll see if you ever go to urgent care or ER, they'll take x-rays of your ankle and the foot to make sure you don't have a fracture of your fifth metatarsal, the long bone behind your pinky toe. Most of these don't require surgery, luckily, but you are in a walking boot for about 6 to 8 weeks. So whenever you have fractures of bones, it takes at least 6 to 8 weeks for new bone to grow for you to come out of the boot or the cast. As far as complete bone healing, it's up to a year. Again, it doesn't mean you can't be in a regular shoe after 2 months. It all depends on, if your vitamin D and calcium is low, if you're diabetic, if you're a smoker, if you have poor circulation. So all that affects your bone healing as well. All right. Now, arthritis of the foot and ankle. There's so many to talk about. I'll just brush over the more common ones. But you can have what we call primary arthritis. That's just normal wear and tear of the joint. Then post-traumatic arthritis, that's where you've had a sprain, a fracture, any kind of injury, something dropped on your foot, you can get arthritis because of that injury. And I'm sure all of you have heard of rheumatoid. So rheumatoid arthritis is a diagnosis typically done through blood work, seeing a rheumatologist, sometimes your primary care. Has anyone heard of psoriatic arthritis?
I have.
You do? Oh, goodness. So psoriatic arthritis doesn't always have to show up on your skin first. So there's about 30 to 40% where it will show up in your joints first before it shows up on your skin, as far as, a rash and plaques. And then who here has heard of gout? So gout, definitely, because it affects your joints. It can also affect your Achilles tendon because that's the largest tendon in your body. But gout is a big form of arthritis. The reason why it affects your feet and ankles so often is it's the furthest body part away from your heart. It's also the coolest. And so what tends to happen, and we'll talk more about gout, of why that happens in the foot. So like I mentioned, primary arthritis is wear and tear. You get inflammation and swelling of your cartilage. The cartilage starts to wear down. And those foot conditions that we talked about, pronation and supination, your feet are out of alignment, so you get abnormal wear and tear. So that could lead to arthritis. Again, we have 33 joints per foot. Big toe arthritis, we also call that hallux limitus or hallux rigidus. Rigidus means it's bone on bone. Limitus means it's starting to be, cartilage is thinning out basically. So we see big toe arthritis a lot. And again, it could be from primary arthritis, wear and tear. It could be from rheumatoid, psoriatic. It could be from gout. So big toe joint arthritis, again, hallux rigidus, you can see there's no cartilage there. So if you look at your second, third, fourth, and fifth toes, you see the space between the toes and the metatarsals. So that's a normal joint. That means there's cartilage on either side. And you can see here there is no cartilage there. How does that happen? Again, it could be previous injury, it could be wearing the wrong shoes, it could be pronation or supination. People who, like plumbers, I see it a lot where they're constantly stooping and squatting and bending that big toe. HVAC people. So non-surgical treatment would be, again, proper shoes. When you have a stiff toe joint like that, we usually will do a stiffer insole. That way, any motion in the big toe you have, it'll stop it from moving so you don't get grinding of the joint. Anti-inflammatories, sometimes we'll do a steroid shot in a joint if there's enough room in the joint. And sometimes physical therapy can help, not so much with the joint movement, but if you have weak muscles within the feet or the legs. As far as surgery, it really depends on your bone quality, your overall health, your activity level. We typically have two options for this. It's fuse the joint, which most people, when they hear of fusing the big toe joint, they worry that they won't be able to walk normal. But there are plenty of people who can still run, believe it or not, and get their big toe joint fused. The only reason why we won't fuse the joint, as long as you're healthy, of course, is if you like to wear high heels. So, which if you like to wear high heels, it probably led to you having big toe arthritis. So because their heel is so elevated, it's going to put a lot of pressure on that big toe. So that's the only reason why we wouldn't fuse the big toe. The other option is even more selective. We can do a big toe joint replacement, just like your knee, just like your hip. But again, you have to be the right kind of patient for that to be successful. With any joint replacement, whether it's your hip, shoulder, knee, ankle, toe, there's always, they always talk about within 10 years, you may need another surgery to clean it out and replace the plastic part of it. All right, here's an example of my patient. Again, you can see this is a normal joint. You can see space in between the bones. There's no space here at all. You see spurs, and then on top, this is a big spur, so you would see a big hump on the toe. Some people may get that confused with the bunion, and we'll talk about what a bunion is. So this is fusing the joint. Did great, actually did his other foot, he's walking normal, and it's been over 20 years since he's been living with pain, so now he doesn't have any pain. All right, ankle arthritis. So again, it could be overuse, it could be an injury, it could be a faulty foot structure, such as pronation and supination. So we usually will start, if it's really bad and really stiff, I'm a big fan of some type of brace, and it's usually a custom brace that's made to fit your foot and ankle and your anatomy. If for some reason that can't be covered through insurance, then there's an over-the-counter option. But again, if there's room in the joint, we can always do a steroid injection just to calm it down. It's not a cure, but these are treatments that are conservative to make you more comfortable. The two options for ankle arthritis would be fusion, so making it to, because you have loss of cartilage, the bone is grinding, it's painful. And so fusing it will allow you to still walk. You won't be able to flex your ankle, but you have 32 other joints, right? So those other joints, unless you have arthritis in those joints, will be able to move. And then for a very select group of patients, I do a total ankle replacement. Here's an example of ankle fusion. So again, this is a normal joint. You can see separation between the bones. You can't really see any separation here. This person has too much pronation, so the ankle has worn out the joint because the heel is going outward. And so with this particular patient, we fused the joint. Again, got to have the right kind of shoes, but from here towards the toes, all of that will still move. All right, as far as the ankle replacement, here's a patient of mine in her 70s, no diabetes, no circulation problems. She does have thyroid issues. She had an ankle fracture. You can see they left some pins in there. But again, there's a little bit of space here, but no space along the ankle joint. So look at this, there's a lot of space now. And so I did an ankle replacement. And again, you can see some spurs on the front and the back of the ankle. And she's doing fantastic. All right, gout. So gout is more commonly from your choice in foods or your diet. Sometimes we can have hereditary gout, and that's where your body can't break down. There's a genetic component where your body can't break down purines. Well, foods that are high in purines would be, believe it or not, eating too much spinach or too much cauliflower can cause gout. It's healthy, right? But who would have thought? But I don't think anyone is out there overdoing salads. I doubt it. Your red meats, especially fatty red meat, deli meat, seafood, alcohol, some beans. So again, everything in moderation, but if you have a history of gout, you probably have to back off of that. So if you do romaine lettuce, that's okay, but too much of the dark green vegetables, again, too much. I don't think anyone's eating too much, to be honest. But the other things, your bologna sandwiches, your deli meat, that's a common one here in the South. Again, because of the purines can't get broken down, and it's from the foods and alcohol and drinks that we ingest, it will lead to uric acid. It's in your bloodstream, and once it settles into a cooler part of your body, typically your feet, then it will start to lay down crystals. So this is an extreme form of gout. I've had to amputate a toe because he had so much gout that it started bursting through the skin. And it's a very, very, very painful condition, even before you get to this extreme. So there's two ways to typically test it. The easy way is a blood test to check your uric acid level. Even though you might be normal, we tend to want to make sure that you're well below the normal range, just to make sure. And sometimes you have to be on lifelong medication, such as allopurinol. Nowadays they have, infusions that you can do for worse cases of gout where you've tried everything else. And then if it gets to this point where it's destroying the joint, usually that's a surgery procedure to clean out those crystals. And what it looks like is, I don't want to turn anyone's stomach, but it looks almost like chalk. It could be dry or it could be kind of cheesy. And again, the big toe joint is very common, but it can affect any joint. All right, like I mentioned, some type of medication. If you have an acute gout, meaning it just happened within 24 hours, they may prescribe something called colchicine, which with that medication, it's only taken, the first day. It can cause major diarrhea. You can sometimes do a steroid injection. The other way to test for gout is if we're going to do an injection, I may tap the joint, meaning draw fluid from the joint. Again, that is painful, but we can send that joint fluid off, and they can tell us, looking underneath the microscope, if it's gout. I didn't mention this here, but there is something else called pseudo-gout, which is gout's cousin, basically. But the only way to know, the blood test won't test for pseudo-gout. It would be tapping the joint or biopsying the joint. We want to avoid the foods that lead to gout attacks. We want to make sure we drink plenty of fluids to keep yourself from being dehydrated. Again, our kidneys are processing these purines, and so we want to make sure you're hydrated all year round. And sometimes you just need rest, ice, and elevation to reduce the swelling and inflammation. All right, who here has heard of bunions? All right, so it's more than just a bump. Most people will get confused with a callus or a corn with a bunion, but calluses and corns are skin problems. A bunion is a bone problem. And so what happens, and we'll show you on x-ray, is these bones are parallel, they're lined up next to each other. So over time, because of pronation, so we don't see very high arch people with bunions, and you'll notice that. But because of pronation, where you're putting too much stress and motion along the inside of your foot and ankle, this bone will start to drift out and we'll see a bump. That's the head of this bone. The big toe joint will start to move towards the other toes. So the bones become out of alignment. So here's a patient of mine. See how your second and third metatarsals, the long bones behind the toes, see these are nice and next to each other? This one doesn't look lined up, right? So over time, because of pronation, this bone has shifted this way towards the inside, and the big toe is going towards the second toe. So non-surgical treatment, I always want to try that. I don't, unless it's life or death, like I had an emergency surgery this morning, I don't always jump to surgery. We always want to try conservative treatment. Now, if you come to me and people have already tried that, then we can talk more about surgery. But modifying your activity and your shoe gear. So with bunions, you can get a bunion on this side as well. She does have a little bit of hammer toes. Wider shoes, will help. Look, if you look at the shape of her foot, it almost looks like the shape of a heel, a pointed heel, right? So people who have, I've heard stories where patients have worn tight shoes their whole life because that's all their parents could afford. That can make your bunions and hammer toes worse. You can try taping the bunion, pulling it over. You can try a bunion shield so that it cushions right here when you wear a shoe, and some type of insole and orthotic. Now, surgical treatment, again, only if you tried everything and it still hurts. It's painful no matter what. But what we do is correct that bone deformity. I was the first to perform bunion surgery through a minimally invasive technique in 2019 here in Middle Tennessee. And so, I've had many years of doing this, but minimally invasive bunion surgery is a lot more doable than your traditional bunion surgery, they've been doing over the last 25 plus years. And we'll talk a little bit about that. So minimally invasive means you make smaller cuts in the skin. So instead of like when you remove your gallbladder or appendix, they just make small little cuts. They stick a camera in versus a big cut to remove your gallbladder. Traditional bunion surgery, your incision would be from here all the way down. So by making smaller cuts in the skin, the patients see less of an incision, so you have less scarring, you have less inflammation, you have less swelling. We still have to cut into the bone and shift it over, and we hold it in place with either screws or a plate with screws. But you can see her outcome is really good. She can walk right after surgery. She's in something like this or a short boot. So this will allow you to put weight on your foot without bending the bone so it can heal. You're usually in this for only 6 weeks. So again, you can walk around the house. I wouldn't do more than 20 or 30 minutes of walking for your first 2 weeks so that your skin can heal, but you can still move around. If it's your left foot, you can drive. If it was your right foot, you won't be able to drive with this on. Here's a really cool case that I did. So this patient has really extreme bunions. You can see the hammer toes, or we'll talk more about hammer toes. I mean, they're just dislocated. This patient had rheumatoid arthritis. And so would you believe that this is the same foot? And do you see any scars? So this was done all through a minimally invasive surgery technique. So even when I present to surgeons across the country, they're always, they give me the same reaction as you do. All right, hammer toes. So these are normal toes. See, they're lying flat. There's different types of hammer toes. I won't bore you with the details. If you have that and we have a consult with each other, we can talk about the details. But it's where any of those 3 joints within the toe bend. It can bend upwards. It can go to the left or to the right. It can go over the big toe, over the next toe. Those are all hammer toes. So I didn't really put it on here, but why does that happen? Again, too much pronation, too much supination. Over time, your tendons will get tight. The opposite tendon that helps bring the toe down gets tight. And then so the tendon on top of the toe pulls the toe up. That's the more common reason. The other reason you can have this would be, if you have like Charcot-Marie-Tooth disease, if you had an injury to the toe and you broke it, for example, and you didn't really treat it, because most people think you can't do anything with broken toes. That's actually not true. You can always buddy splint it so you don't get hammer toes, for example. But even then, let's say you broke it and it was fine. Because of that trauma, you can get post-traumatic arthritis in that joint, which can lead to a hammer toe. Wearing the wrong fitting shoes, again, if you look at this shape, it looks almost like a heel, right? The front of a heel shoe. So too narrow of a shoe can make it worse. Conservative treatment would be, this is a type of toe taping or strapping you can do. Again, wider toe box shoe gear so it doesn't rub on the top. You can do toe spacers. It all depends on where your complaint is. Some people may complain of a callus at the tip or a corn on either side of the toe or on the top. So surgery is really going to depend on, if you have pain no matter what, trying the conservative treatment. We look at your x-rays, we look at your activity level and other factors like that. If you do a lot of running, unless the joint is stiff, we usually will fuse the joint. But if you do a lot of running where you need to grip, then I won't fuse the joint. We'll do an arthroplasty. But again, here's a hammer toe where it just sticks straight up, and then these are kind of moving over towards the big toe. So ball of foot pain, I've had this myself as well. The more common reason for that is tight calf muscles. So if your heel can't fully come to the ground, you're putting more weight on the ball of your foot. That makes sense, right? Most people will describe it as swelling. They'll point to the ball of the foot. They may say it feels like a marble or a rock or a bunched up sock. You'll have swelling and pain there. It just hurts to walk, especially barefoot. Also, over time with age, we lose a lot of fat here. So my patients will say, well, why can't I lose fat anywhere else? But again, it's because we're putting so much weight on our feet. The average American puts on 75,000 miles by the time they're 50. So everyone here is over 50, right? So you've put on at least 75,000 miles if you're an average walker. So that's a lot of miles on your feet. So you're going to get wear and tear. But the fat here just dissipates over time. For people who they don't want to do surgery, believe it or not, there are fat pad injections. Again, it's out of pocket. It's not covered by insurance. But it's where they take fat from another human, and then they'll say, well, why can't you take fat from my belly and put it on my foot? Technically, if I pair up with a plastic surgeon, we could probably do that. But again, those are out-of-pocket costs. All right. So conservative treatment would be, a lot of times when you have ball of foot pain, your toes will start to drift up. So if your toes are flat, the ball of your foot is flat, right? Because the joint is flat. So as the toes drift up, you can really feel the bones there. And so by taping it, as long as it doesn't have arthritis, you can bring the toes back down, and that will help relax it. Another thing I like is putting a metatarsal pad. So remember we talked, this is the transverse arch, the third arch in your foot behind the ball of your foot. So this is flat. So putting a pad behind there will help lift the joints and kind of relax the toes. Again, stretching exercises because of tight calf muscles, making sure you wear a wide toe box shoe. And instead of just putting a pad here, they make insoles that have a pad built in if you have this type of ball of foot pain. Again, surgery is only when conservative treatments fail. We've tried everything and you're a healthy patient for surgery. What we usually have to do is, we usually have to cut the bones here. So if you only have pain here, for example, see this bone is actually longer than the next one. So we would cut the bone there, put a screw there, and then it would lift the bone up so you're not walking on that part. With that surgery, you are weight bearing in a surgical shoe for about 6 to 8 weeks. So again, you're not bed bound or anything like that. All right. Ingrown toenails. I've had them myself. Anyone else? All right. Believe it or not, I've seen newborns or people or patients within a few months old have ingrowns, and so it can be hereditary. Chances are you have a parent who's dealt with it. Also trauma. We drop things on our toes. We stub our toes. Our toes take a beating all the time. Wearing too tight shoes. It's pushing on the toenails. Again, you're not feeling it as you're walking until you start to get the ingrown. So it kind of happens over time. If you don't trim your nails properly, so with toenails, this cartoon doesn't do a good job, but you really need to let it grow out past the skin edges, and it needs to be cut straight across. Shoes that are too tight, and then if you have fungal toenails, if you have a split in your toenail, if you have psoriasis, certain conditions can lead to nail problems and skin problems. So how do we fix it? Well, we talked about how to trim it properly. If you already have a deep ingrown where it's already red, swollen, or if you have infection with pus and drainage, we usually will do a toenail procedure in the office. I numb up the toe. It'll be really numb. That's the worst part of the procedure because ironically, to numb up your toe, it hurts. But depending on, if you have it ingrown just this corner or that corner or both, we'll cut it all the way back to where it grows, remove the entire thing, and then if it's infected, that's all we do. You soak it in Epsom salt. We give you specific instructions. You put a little bit of antibiotic ointment and then a Band-Aid. The first day of the procedure, we have these bandages because it will bleed. So that's to make it a little bit tight so it stops bleeding. If you don't have an infection, we do a chemical back here where the nail grows so it won't grow back. The other option is, I've seen it really bad where you can see the nail come out through the skin on the bottom. So I'll remove the entire toenail at that point because the infection is so bad. Kids are really bad at this. They'll let it go, and then what most people don't realize, I've had to amputate a toe because of this, especially in a diabetic or someone who smokes or has poor circulation. And it's because underneath your nail is a thin piece of skin. Underneath that skin is your bone. So it's very easy for high-risk people to get a bone infection from something as simple as an ingrown toenail. All right, fungal nails. So the only way you can really diagnose if a nail has fungus is to actually take a clipping of the toenail and send it to the lab. Now, you can look at this and say, oh, this is fungus, but really, most likely it is, but I like to diagnose it by sending a sample of the nail. That way we can really cater your treatment to treat it and all that, because it could be other things. It could be yeast, it could be mold. I know it sounds gross. It could be bacteria, and it could just be trauma to the nail, meaning just repetitive trauma. If you have hammer toes, the nail is constantly hitting the bottom of your shoe. So that can cause the nail to be thick and discolored. So not all funky toenails are fungus. So fungal nails is onychomycosis. Anything with mycosis is fungal. Onycho is Greek for toenail, and then fungus. So onychomycosis. So what are the treatments? It really depends on how deep that fungus is in the toenail, how damaged that toenail is, and really the expectation of the patient. Are they just wanting to make it look clearer, or are they having pain with it? It really depends on what the goals are. I'll be the first to say fungus is very hard to get rid of when it's deep in the toenail, when it's already misshapen. So right here, this skin, this nail will never go past this skin. So the skin underneath the nail got damaged somehow. Could be from trauma, could be from the fungus. Could we make it straight here, like by trimming it and make it a little bit more clear? Yes, but it'll never be as clear as this when it's that involved. There's topical treatments. The stuff over the counter, honestly, they're not great unless you have superficial fungus. This is what I have in the office. Insurance won't cover it, of course, but this is an antifungal nail renewal solution. It's oil-based, meaning it will penetrate the nail. It has urea, it has vitamin E and A oil to help with the appearance of the nail, and it has an antifungal in there. Again, for your deeper involved toenail fungus, especially if there's fungus around the skin, which that can happen, where you may have athlete's foot first and then you get a fungal toenail infection, or vice versa. But an oral medication, again, we check your liver to make sure it's healthy before we prescribe anything like that, and to make sure you don't have medications you're taking that would interfere with that. Laser therapy with these two treatments have the better outcomes for deep toenail infection, but guess what? This is thousands of dollars. So most people can't afford it. And then really teaching you all about foot hygiene and shoe hygiene. So fungus and bacteria live on our skin. That's normal. It's just when it becomes too much fungus in one area where it infects your skin or your toenail, then that becomes a problem. But it lives on our skin, it lives in our socks, it lives in our shoes. So it's good to, disinfect your shoes. I always tell my patients to wash their socks together, nothing else with it. Wash them inside out. It's a pain in the butt to make them not inside out, to put them together. But if you turn your socks inside out, you'll notice the inside is a lot more fabric-y. And so your dead skin, fungus, bacteria still live in there. So, all right, so this kind of leads into athlete's foot. We call it tinea pedis. Pedis is foot, tinea is fungus of the skin. And so, again, I like to diagnose it by taking a biopsy or skin scraping, but usually when we see it like this, we know it's fungus. We usually start with some type of topical treatment. We talk about shoe and socks hygiene. And again, it may not itch, it may not hurt, but if I see this, I usually will tell patients, hey, you have fungus on your skin. And they'll say, really? And sometimes they want to treat it and sometimes they don't. But again, it can creep up into the toenail. All right, so treatments, again, foot hygiene, shoe hygiene. One thing I always tell patients, especially diabetics, is I don't think we, in general, not everybody, we do a good enough job cleaning between our toes. And a part of that is because some people can't reach in between their toes. So you can do like a soft sponge or brush and try to, if you have a stool on your shower, put your foot there. That way you have a shorter distance and really clean in between the toes. The next thing would be really dry in between your toes, because I see moisture trapped in there all the time. That can lead to an opening in your skin. It can lead to cellulitis. And of course, you know, athlete's foot. And for people who still have good feeling in the feet, it'll burn. It'll actually burn. It's like a split in your skin. For your shoes, if you have sweaty feet, you know, change your socks often. Cotton socks tend to be, they hold on too much moisture. So keep that in mind. If you are walking or exercising, I would avoid cotton socks. I would do bamboo, or wool is pretty thick, but hikers wear it for a reason. It does keep moisture out. And then your athletic blend. So your athletic type of sock is good for, you know, walking and exercise. You can do shoe powders to disinfect the shoe or dry out the shoe, put it in the sun. You can actually use an antiperspirant for your feet. So if you go to the deodorant aisle, they'll have some that just say antiperspirant. All that means is it keeps it from getting sweaty. And if you like onions and garlic, like I do, that can lead to more sweaty feet. So something to keep in mind. Sometimes in worst case scenarios, we'll do oral antifungal medication, but most of the time we do a topical medication and talk about foot hygiene. So this is just an example of an antifungal spray you could put in the shoe. All right, plantar warts. So believe it or not, this is caused by the human papillomavirus. We see it a lot in all ages, but especially children, or people who tend to garden or work in soil, and anyone who likes to go barefoot. But whenever I see a patient with a plantar wart, usually it looks like a callus. If we look closer, you can see little dots. Those are dry blood areas, because the wart causes the capillaries in your skin to be abnormal, and so it looks like little dots. It's typically really painful. The first thing I ask the patient if they have warts on their feet is, do you have warts anywhere else on your body? Sometimes they'll say yes, sometimes they'll say no, but if you have warts anywhere else on your body, you have to treat those, otherwise the warts on the feet won't go away, again, because it's a virus. Oral medications are not common for this. Usually it's something topical that you put on. We usually shave this down in the office and put medication on top. Sometimes we can freeze it off, but most patients can't tolerate that. It's pretty painful to freeze it. Sometimes some people just want it out, and so I'll numb up that area and just cut it out. By cutting it out, you can't really put stitches there, so we just let it heal from the inside out. All right, really popular topic, corns and calluses. What's the difference? Basically, both are too much keratin on the top of your skin. Corns are typically on top of the toes or on the side of the toes. If it's at the tips of the toes, on the bottom of the foot, on the side of the foot, it's a callus. Either way, it's the same thing. It's too much keratin. On the bottom of the foot, it's because there's too much pressure in that spot. On the top of the foot, usually because it's a hammer toe, or it's rubbing your shoes because your shoes are too narrow. But it's our body's way of trying to protect that area from becoming a sore or becoming a blister. These are really dangerous in a diabetic, especially a diabetic who has poor circulation, poor feeling, and diabetes that's not controlled. These lead to ulcers, which lead to infection all the time. So how do we treat it? Well, these are just some examples. These are the two things I recommend the most. So As long as you have good feeling and good circulation, this is not an aggressive, if you're at the health fair, we gave some of these out, if you were there. But it's a foot file. It's almost like a pumice stone. It's not too aggressive, but it's good to do right after a shower, or after soaking, or in the shower where your skin is soft. And then ammonium lactate or urea, what those do are they're specifically for calluses and corns. It helps kind of break down that keratin and make it softer. So the combination of these three things is sometimes soaking your feet feels good. It can be therapeutic. This is about 2 tablespoons of Epsom salt and enough water to submerge your feet. The only reason you would not soak your feet is if you have any open sores, if you have poor circulation, or if you have poor feeling, meaning you can't tell if the water is too hot. So you don't want to do that if you can't tell. Hopefully you still have feeling in your hands. I told a patient yesterday who had neuropathy really bad, no feeling in the hands or the feet. So I said, take a thermometer and stick it in the water to tell that way. All right, now let's move on to diabetes and foot health. Again, this topic alone we can spend weeks on, but I just kind of want to brush up on why this is important. Anyone here diabetic? If they want to, I'm a diabetic too, type 2. So every 30 seconds, someone in the world is losing their leg due to diabetes. Every 30 seconds. And this statistic is about 5+ years old. So I'd be curious to know what that statistic is now. And these diabetes-related complications could be from foot ulcers, poor circulation, neuropathy, and something called Charcot foot and ankle. We won't spend too much time on this, but this is something I specialize in as far as the care and treatment and surgery for that. Now, I show this to surgeons across the country all the time. I was at a conference 2 weeks ago, and 3 of us who gave talks in a row showed this same chart. So I won't bore you with the details, but what this is showing is breast cancer, Charcot, diabetic foot ulcer, all cancers combined except for lung cancer, minor amputation, limb ischemia, meaning very, very poor blood flow, and then a major amputation is above the knee or below the knee. What this shows is the 5-year mortality rate for these conditions. So for those who have undergone major amputation, they have a 56.6% chance of dying within 5 years. Breast cancer is 9%. Prostate cancer, all other cancers are below this amputation with the exception of lung cancer. So the only thing that beats out diabetes complication once you lose a limb, have poor circulation, is lung cancer. So when it comes to diabetes, I don't think we take it seriously enough. If you come into a room, you see your doctor and they say, Sally, you have breast cancer. Most patients will want to seek treatment, right? Or if, depending on their age or how far it is, they may not want any treatment. If you say, Sally, you have diabetes, well, okay, I'll lay off the sweets, or I won't drink Mountain Dew, or, but they don't really take it seriously until something happens, like an infection where they're close to losing their leg, or this morning I had to amputate a toe before coming here. So, and that gentleman already lost the leg. So having already lost the leg, again, he has a 56.6% chance of passing away in 5 years. So this is why diabetes is important. If there's anything you get from this lecture is make sure if you have diabetes, your family members, your friends, they take it seriously. All right, what about costs, right? With Medicare, Medicaid, we're contributing to the costs of this health policy, right, for everyone. So the cost of cancer in 2015 was $80 billion for all cancer. The cost of diabetes, $237 billion in 2017. So it's only gone up from here. A third of these costs, a third of $237 billion was related to the foot and ankle, meaning diabetic foot infections, amputations, poor circulation, neuropathy. So it's a big cost driver of healthcare, and again, I don't think we're taking it seriously enough. So self-care is key. You want to check your feet daily. So I have patients, because of their diabetes, they're blind. or they can't see well. So that's something I make sure to ask the patient. In that case, that's where hopefully you have a family member who can help you, or we typically will see these high-risk diabetics every 3 months, meaning they've already had an amputation, they've had a wound. We watch them every 2 to 3 months. I saw a new patient with diabetes. Feet are fantastic, so I only would see that person once a year or every 6 months. So check your feet. For people who have a hard time reaching their feet, we have you take a mirror and you can check it that way. Look for changes in color, temperature, hair growth. With age, we tend to lose hair on our legs and our toes. That has to do with circulation getting weaker. But any changes in your nails, your skin, in a diabetic, you want to look out for. In between visits, if you notice any wounds, you have to see someone right away. So this gentleman lost his toe this morning because he treated his own callus. And then, of course, we have to make sure our blood sugar levels are good. Eat as healthy as you can. Do I eat healthy 100% of the time? No, but when I saw my doctor on Monday, she said I need to eat more carbs because my diet is a little too good sometimes. And I exercise 5 days a week. My A1C is 4.4. So, all right, regular health checkups. So that's your primary. My doctor always asks, when would you have an eye exam? Every year, and I did. If you have kidney problems, you want to see your kidney doctor. It takes a whole team. It's not just one doctor, typically, that helps make sure that head to toe, your heart, diabetes affects your heart, make sure that you're healthy overall. The important thing about podiatry and diabetes is whenever we see manifestation in the feet, that means there's something else going on. It could mean that your heart is getting weaker, you have poor circulation, you're having kidney problems. It's a late sign that there's other things going on, not just with your feet. You just can't see your heart, you can't see your kidneys, Again, at least an annual exam with a podiatrist for a foot exam. If you're high risk, meaning you've already had a wound, or you've had a wound and it healed, or you've had a toe amputation or a limb amputation, we see you more often because you're at higher risk of developing ulcers. The number one risk factor for getting an ulcer is already having had one. Shoes matter. So, Medicare has a good program for diabetic shoes and insoles. It is like breaking through Fort Knox to get them. How it works is I usually will send a prescription to a company, hopefully local, that will fit you for a diabetic shoe and insole. However, whoever manages your diabetes, whether it's your primary provider or endocrinologist, they have to send in their paperwork. So shoe matters. Really, you shouldn't be barefoot as a diabetic, but especially if you don't have full feeling on your feet. I've pulled out many weird things from feet because they didn't feel it. I've had to amputate half a toe because a patient went barefoot and had a staple in their foot. But they didn't feel it because they have no feeling. There was a lima bean one time too. Yeah. Again, you want to make sure you choose the right shoes, and we'll talk specifically about that for what you're doing. So this is an example of a diabetic shoe. This patient doesn't want to worry about laces, so if there's swelling, you can loosen up the Velcro. So that's pretty convenient, and it's easy to slide into. But again, some people are more conscientious about their style, but when it comes to feet, there's a compromise between style and function. So, but they do make better looking diabetic shoes than before. All right, and again, wounds can't wait. This patient has already lost 2 toes, so we don't want them to wait, especially with calluses, blisters, and all of that. High blood sugar will make it very hard to heal. So I can't tell you how many times I've had to amputate, and they're like, why does this keep happening? Well, your blood sugar, your A1C is 13. I mean, you have to take accountability on your end. All right, if it's an emergency, if you stepped on something, foreign object, it's better to go to urgent care, honestly, emergency room, even though it's a long wait. A lot of what I've found, and I hate to say this, but some urgent cares won't do anything. It may be above their experience level to numb you up and kind of pull something out of the foot. So it might be better to go to the emergency room if you are diabetic or have poor circulation or neuropathy. Just a quick thing on neuropathy, not everyone who has diabetes get neuropathy, and not everyone who has neuropathy has diabetes. It's just the most common reason for neuropathy in the United States is diabetes. But you can have neuropathy from cancer treatments, you can have neuropathy from a spine issue, your lower spine, you can have neuropathy hereditary. So again, it's not always diabetes with neuropathy, but that's the most common reason. All right, so there's a study by Duke University that showed that patients who had Medicare with diabetes were less likely to have an amputation if a podiatrist was part of their care team. Also, there's a lower risk of amputations, patients with severe extremity complications who only saw a podiatrist had a lower risk of amputation. So we tend to be, the patient's best advocate. Sometimes we even have to step up and coordinate, going to see a vascular doctor. Hey, you should see your primary. So we do a lot to make sure that we save your limbs, which will, prolong your life, save your life. Ideally, you want multiple people on your care team, like I mentioned before, your primary, your eye doctor, your kidney doctor, heart doctor, podiatrist. That will reduce your amputation. Now, the American Diabetes Association has so much free information, whether it's on diet, your heart, any part of the body, but they do have a place for your feet. So if you want to jot this down or take a picture, it'll talk more about, what to look for with your feet, how to care for your feet. All right, choosing the right shoes. So this is what I tell patients. I'm going to take my shoe off. And I always recommend that you untie your shoes. Sometimes I get lazy and I won't untie it. So this brand is called Altra, A-L-T-R-A. And I'll tell you why I like it. But the first thing I tell patients is the toe needs to bend because that pushes you forward. Can everyone see? That's the first test there, right? What we don't want is for the middle of the shoe to bend. So I'll try to bend it, but it won't bend in the middle. So if your shoe bends in the middle, your joints are taking that extra stress and that force. The last test is, the middle test is if I can turn my shoe, like wring it like a towel, that's too flexible. Again, your foot is inside the shoe. It's going to take a lot of that stress and that force. So see, I can't twist it, all right? I can't bend the middle, only the toe. That needs to bend, but not the middle. And I can't twist it. The last thing is the heel counter, which is where your heel sits. I can't collapse it, meaning it has enough support. It's not going to fall down on me. So that's what we look for in a good shoe. The exception would be, obviously boots, casual dress shoes, heels. You can't do this test. Those are not good shoes for you anyway. But if you're going to church, you're only wearing it for an hour or two, right? So you kind of have to deal with the aches and pains if you want to wear cute shoes. But what I particularly like about Ultras, I used to wear Hoka's and Brooks and Saucony, is the toe box of the Ultra is more shaped like your foot. So if I were to compare anyone else's sneaker side by side, it would come more to a point, whereas this is more rounded off. So this is not a wide shoe. This is a normal width shoe for Ultra. So when your toes have room to move, it helps with your balance. Your arches can be more supported. What I like so I have tight calf muscles, I've had plantar fasciitis, I've had ball foot pain. Again, not everyone would be a candidate for a zero drop shoe, but zero drop means the heel is at the same level as the ball of the foot. So a lot of these shoes, you'll see the heel is a little bit higher, 2 to 4 millimeters higher. It's not that big of a difference. But for walking, that's okay. Because when you're walking and you're walking at a good pace, you're doing a lot of kind of rocking heel toe. So with the walking shoe, look how much cushion there is. The only reason why I would not recommend this much cushion is if you have a balance problem, meaning on just regular shoes, you kind of have a balance problem. But if you do, you can still wear these shoes and use a cane or a walker. But again, these are not leather on top. So if you have bunions, hammer toes, this is more breathable fabric on top. But if I were to try to flex the shoe in the middle, it won't bend, it won't bend, and it won't bend. The heel has plenty of support. Some people like the heel counter going upward to kind of cushion that Achilles tendon because there's not a lot of fat there. See, these kind of go up. So that prevents blisters when you're doing a lot of walking. For some people, this is a good running shoe as well because of the way it's kind of like a rocker bottom. But again, New Balance has numbers on the shoes. Anything above 500 is a very stable, sturdy shoe. All right, daily shoes. I get asked this a lot. I'm gonna put my shoe back on. So daily shoes. How many people like wearing like house slippers? Okay. Not all house slippers are good. So this one is good because the sole is stiff. Not like your feet will still bend, but it has a thicker sole that's more durable than like what you would find at Walmart, for example. So this is the brand Kuru, K-U-R-U. And these are, again, there's different brands. These you just slip right in. So if you like the Skechers slip-ons, again, those are too flexible. But if you don't want to spend money on shoes, you want to wait till they wear out, then you can always replace the insole inside those Skechers slip-ons, so you don't have to worry about bending over to tie them. Put a good insole in there, and we'll talk about that here soon, and that will make it less flexible. Vionic is for those who are more fashion forward. They actually make flats and heels and wedges, but it's more orthopedic in mind, your foot structure in mind. They make casual shoes. They're deep enough that you can get a good insole. What I like about all these shoes is that you can put a good insole inside of them. And of course, Merrell, you've probably heard of, are good shoes for casual shoes as well. All right, summertime. We can't wear shoes, closed-toe shoes all the time, right? Anyone likes to wear sandals? I do. In fact, when I get home after being on my feet all day, exercising, even after a workout, I wear this specifically. These are called OFOS, O-O-F-O-S. So this rubber is a lot more durable than, again, like your Adidas or Nike slide. This was developed by athletes where after practicing or playing games, wearing cleats, basketball shoes, whatever shoes, tennis shoes, they needed a sandal that was better than the Nike, the Adidas, and all that, that would have arch support. So there's arch support on the outside, on the inside, and going across, right? Those three arches that we talked about. And again, this is a more durable EVA rubber than what you would find. And there's slide-ons. Here's the same sandal, but more thong type, if you like that style versus a slide. Now, for those of you who have neuropathy or have balance problems, I recommend straps if you want to wear sandals. So see how it goes around the heel and it supports the midfoot. So you're less likely to slide out of this. This is a Chaco sandal, very popular with kids and teenagers, but it's actually a sandal meant for hiking. So if it's sturdy enough, durable enough for hiking, it's durable enough for everyday walking during the summertime, of course. All right, so arch supports, inserts, and insoles. They're all the same thing. Everybody calls it something different. The only thing that's different is an orthotic. So this is custom made. A custom orthotic where they take either a mold with plaster or fiberglass, or they have you stand on a foam. Those are like $300 to $600. So it's not even as expensive as you were saying for the off-the-shelf. But these are some good brands. I know it's hard to read. Power Step. You can find these at Fleet Feet, on Amazon. I don't think Dick's Sporting Goods have it, but they have something called Super Feet, which is okay too. What I have in the office, the brand is called Ready Thotics, REDI, Thotics, so THOTICH. All of these are podiatrist approved because even though it's over the counter, you know, we still have you stand on it. We make sure it's appropriate for your feet, but they have anything from low arches to normal arches to high arches. If we need more support than that, we can, you know, they have different styles to match the foot. So these vary from $50 to $70. And it should last you a year unless you do 10,000 plus steps a day. It might last you 6 to 8 months. So, but these will fit into athletic shoes. I don't have it on here, but they make insoles for like when you have to wear dress shoes just to give you some support. But again, dress shoes aren't that supportive, so it will cause some pain if you're wearing it all day. All right, so here's a list of all the shoes that are approved by podiatrists. Here's the website, you can take a picture of it. So if you have a brand of shoe you love, you're curious to see if podiatrists would approve of it, you can look there. Or even if you're curious, I'm like, I've heard about Hokas today, or I've heard about Ultras, you know, do I want to spend the money on that? Again, the best thing to do is to try them on because what may work for you may not work for you. So, all right, so movement is medicine. This is another thing I'm passionate about and why over the last year and a half, I've really focused on strength training. I saw a list of programs that is offered here, and there's different like beginner, intermediate, advanced on like strength training. Everybody knows about cardio, right? Honestly, I think walking is the best cardio you can do. It's free, you can walk anywhere, you don't need special equipment, so that's good to work your joints and your heart. But what about your bones and your muscle? So that's where strength training comes into play. It helps combat age-related muscle loss. We call that sarcopenia. Your muscles attached to your bones, right, through your tendons. So by having more lean muscle mass, it improves your bone health. One of the high mortality rates in the senior population is falling. You've heard of people who fall and break their leg or their hip, then they go to the nursing home, and then that's it. They usually pass away not too long after that. So how do we prevent that? Mobility exercises like they have here, but all of that stems to making sure you have good muscle tone. For women who are scared to look manly or muscular, it is impossible to look that way without steroids. So you will not overdo it. You will not look manly at all. It takes a lot of good nutrition. I mean, you're comparing yourself to bodybuilders, and they do that. They train twice a day. They eat a lot of supplements. They eat a lot of protein. So you're not going to look like that, I promise. And if you do, you have amazing genetics. Muscle burns fat. We forget that muscle is a metabolizer, right? Because of that, there have been studies that show, especially with diabetes, the more lean muscle mass you put on, you have more insulin receptors, meaning you're going to be more sensitive to insulin. You're not going to be as resistant. And that's why my A1C is 4.4. You know, I strength train. It reduces your mortality risks, again, by reducing your risk fall. There's been more studies that it improves your mental health. You know, when I had a personal trainer last year, he was like, why are you here? Like, what's your goal? I'm like, honestly, this is for my mental health. Again, you may be suffering through the workout, but when you're done, you feel a sense of accomplishment, right? Hey, this was hard. I psyched myself out. I knew it was going to be hard, but guess what? I did it. It also will improve your sleep and support your balance because you're stabilizing your joints by having strong muscle. And that's it. So this is the phone number to my office. Here's the address if you want to take a picture of that. I'm right across the street from St. Thomas Rutherford Hospital. You're welcome.